Hey guys, how's it going? Good to see you all on a Wednesday night. Can you hear me okay? Yep, I'm seeing a thumbs up. Seeing some thumbs up. That's cool. Oh, fantastic. Well, it's an absolute pleasure to meet you guys, and hopefully this sort of like relaxed online format is good and allows everybody to just, um, maybe even have a cold beverage or something while we work our way through some of the recent developments in eye disease. But it's a pleasure to meet you all. I work here at Vision for Life Institute with the team, one of the retina specialists here, and um, we were just hoping to, yeah, go through some stuff that I find interesting, and hopefully you find it interesting too. Um, Move to the next screen. Perfect. And so. A little bit about me. Um, I am one of the sort of QUT alumni. We finished up in 2008. Um, so that's with like Fody and Claire and Roz and Panda and a few of the other guys around town. And then I worked for Adelaide in Adelaide and the Gold Coast. And then sort of basically trained here in Sydney. Trained here in Brisbane and did some fellowships here and down in Sydney. And now I'm back. So it's a pleasure to be back. Um, Last time I spoke with the Vision for Life crew, um, I had just had throat surgery, so I could only talk for 10 minutes, but now I can talk for infinity. So I feel bad for you guys now. Anyway, so what I thought we would do today is try and just go through a few things. So just move this out the road um, with a brief outline today. So the past, which is really just consolidating what we know, the present, sort of what's new and upcoming, and then the future, sort of how is this all going to link together, which I think will be um, extremely valuable moving forward. So the past, I guess maybe not the past, maybe the pillars of how we sort of do things from time to time. And also, just while we're getting started as well, of course, if there's any questions, shoot them through. If anyone wants to ask anything, obviously, that'd be great. I'd love to like discuss some cases with you guys as they sort of come up as well. Keep it pretty interactive if you guys are keen. So, I guess sort of dealing with common things, I thought we'd start off by talking about the red eye. And really, that's a pretty common thing. And I remember from my days with OPSM, it's really just a 5 minute add-on between patients, a bit of an itchy scratchy, when really, you know, it can be so much more and can be difficult to sometimes work out what's going on. So what do we do? Essentially, firstly, when the patient hits the deck, we really try and establish what's going on with a good history. And these are all the cardinal features of history taking, the time course, the company it keeps, whether there's pain, redness, discharge, photosensitivity, what risk factors the patient might have presented with, whether they're a contact lens wearer or they've had a recent injury, and then sort of a review of systems to see what else might be going on or might have led to the patient having a red eye. I think these are all things which can be done uh, in the chair pretty routinely. Vision, pressure, pupils, fields, checking the motility, fluorescein, as part of the sort of a systems-based examination, which shouldn't be a big surprise to anybody, sort of those things that are there. And that's sort of really, this would be able to be performed by really GPs or optometrists. However, where these sort of eye specialist optometrists shine is actually measuring a good pressure rather than just digitally assessing slit lamp examination and supplementing your examination with multimodal imaging of the anterior and posterior segment, which is kind of, where contemporary optometry practice is at the moment, which is great. And so I just kind of had a couple of like cases here, and you know, having a look here, I mean, it's tough because everyone's on, but does anybody want to shout out maybe this sort of top middle image, like what they think might be going on there? Or is everyone kind of muted? Oh, well, you can pop it in the chat. So, all right, that's cool. Yeah. So, this top middle one here, um, you know, that, we could recognize quite clearly as a bacterial conjunctivitis. We've got an epithelial abrasion in the top right-hand corner, and then some good going adenoviral conjunctivitis on the bottom there. And so, really, no, these don't need referral. These can be easily managed. And then these ones here, once again, looking through, this gentleman's got quite, in the top left image, he's got quite an unhealthy eyes. There's a piece of metal sticking out of it. We've obviously got a large hypopyon in the top right image and a very sore eye. The slit beam showing a really narrow anterior chamber here on this eye with a cloudy cornea, and then, hyperpurulent discharge. So we're looking at a foreign body, endophthalmitis, acute angle closure, gonorrhea, conjunctivitis. You know, Clearly these things can go sideways quite quickly and they would need referral. But probably what we're most commonly presented with is this kind of thing where we really don't know what it is at the outset, and it could be somewhat important or could be really quite simple to manage. And so it's just important to have a systems-based approach to looking at these patients. I think really when we're thinking about the history, when people have a rapid onset, a suspicious mechanism such as people hammering or chiseling or getting stabbed in the eye by organic matter, they've had a recent surgery or trauma, or they've got unusual features, either that they're an unwell patient or they have risk factors or things don't quite line up. I think that's always good to get a second opinion on. But certainly with um, on examination, when the vision is reduced, there's alteration in intraocular pressure, and only eye, um, the patient's otherwise systemically unwell, or there's specific slit lamp findings that might sort of push you towards referral. But I think those are quite sort of key things to consider. And of course, always just refer if your spidey sense is tingling. And despite this being the worst photo of Spider-Man ever, I think he's actually the photo from above with the severe gonococcal conjunctivitis, it looks like, maybe. Uveitis, one of the things I do work with a little bit here. I think urgent uveitis is really for people with vision loss, high pressure, only eye, children, pregnancy, people who are immunosuppressed, people who have a history of cancer or exotic travel, or if they're otherwise unwell. And I think that that's not going to be a big surprise, that those are things that you would look out for as red flags that this person could be potentially harboring sinister eye disease. So, sort of the pearls here, I think history is more important than ever nowadays when we're trying to sort of triage and appreciate what might be going on. And the devil really does seem to be in the detail. Dilated examination, I think, is often required to know what's going on. And really, we've got a zero tolerance for intraocular inflammation. Investigations, I think if we're thinking about doing bacterial swabs or recommending to the GP for bacterial swabs, I think it's reasonable to consider viral swabs sometimes as well, just so that by the time you get the results back, you can confidently exclude a viral cause. Um, and I think really just the history and examination guide further investigations for these patients. There really isn't a blanket set of things that we would do for every patient every time. So just to highlight how important history can be, this is a 73-year-old lady, and she's presenting with a visual disturbance, and we can see that she's got some floaters in her vision there. But just even something like a few extra words on the history, like that, a renal transplant, which will mean that she'll be immunosuppressed, and that might prompt you to perform a dilated eye exam where she has peripheral retinitis, and this is CMV retinitis. And you can see how just a small tweak in the history can really push you in an entirely different direction. Similarly, again here, 28-year-old man presents with some floaters. Nothing unusual here. However, recent immigration from Iran. So even just a few words on the history, and he's got occlusive retinal vasculitis from tuberculosis infection. And this is one of the great cases that's that sort of had everyone scratching their heads for a while. This was a young lad who came in with reduced vision. I'll open it up. I don't know if we have prizes, I'll ask, but if anybody can remember what that clinical sign is, if this is just at his sort of temporal limbus, that sort of foamy appearance there. If anybody wants to pop that in the comments, what they think that is, before I go on. Um, any takers? No.
This is not enough carrots.
Not enough carrots.
Spots.
Perfect. That's exactly what that is. And so the brother comes to me and he sort of says, "Ah, does it matter that he only ever eats fried chips?" And then, of course, that's right. There's a bitose spots or bitot spots, depending on how ochre you are. And yes, he's got vitamin A deficiency. So that's why he'd lost all of his vision. So it was quite interesting that just to show that even just a little bit of history can be like super, super helpful. Anyway, unrelated to that, so that's the first part done. That's sort of the pillars of ophthalmology, the approach to the red eye, and just sort of summarizing history and examination. This is an interesting case from Mount Gravatt. This is a 32-year-old woman who presented for review. She'd had a 6-year history of normal tension glaucoma. She had vision of 6 and 6 in both eyes, and the pressure was normal. And I sort of asked her, like, why did you think you had glaucoma? Like, how did this come about? She's like, oh, I had some blurry patches in my vision. And that's how it all got picked up. So she was symptomatic with something happening, which I think is unusual for glaucoma. And having a look at her imaging, normal, healthy looking eyes, normal autofluorescence. However, she represented having lost all of her vision. And this is a bit of a tricky scan to interpret here, but looking at the right OCT, you can see that the whole inner retina is completely thin and atrophic, um, which is consistent with a vascular insult. And looking at her left eye, you can maybe even appreciate out in the temporal macular area, there also is a bit of thinning out there too, which is a bit unusual. So we put together all of her sort of color maps over the years. And the top eye is the right eye, of course, and that didn't really do much over time until she infarcted her macula in the right eye. But in the left eye, having a look at the sort of middle image, you can see these little tiny spots of retinal thinning pop up. And, if I was thinking that was going to be glaucoma, I would have thought maybe that they would enlarge over time rather than have these new discrete sort of areas. Visual fields were terrible, particularly in the right eye, with that sort of fixation-threatening scotoma. And so thinking this was maybe a vascular cause, I did a fluorescein and that was plumb normal. And then basically, I didn't know what was going on here, but after seeing her every 6 weeks for about 6 months, she popped up with that tiny flame hemorrhage just there in the right eye, and we repeated her fluoro, and she did have uh, active retinal vasculitis in both eyes. And so even though she'd had all these normal investigations and normal fluoresceins, I think sometimes you really just have to keep looking if things don't make sense, and just keep on looking just to make sure until you find the answer that explains everything. So that was a bit of a high stress case. I think she was pregnant at the time, so obviously, you know, one of the ones you watch out for. So this is part number two, the present. And so this is talking a bit more about sort of contemporary sort of updates. And so, I mean, it's hard sort of over Teams, but does anyone have any idea what these sort of three things have in common? The A380, YouTube, and Star Wars Episode 3? Well, basically, they all came out in 2005. So the first video was uploaded to YouTube in 2005, which makes me feel so old. But anyway, where we are now. So basically, the reason of why 2005 is of interest to know is that's really when we started using off-label Avastin for uh, retinal vascular disease, either diabetes, vein occlusion, or AMD. And I sort of popped into ChatGPT to sort of map out sort of the developments. And really, you know, after 2005 and 2007, you've got the PBS listing of Lucentis. Then Eylea comes out in 2013. And then by 2016, all we really have is Lucentis and Eylea for our retinal vascular disorders. Then fast forward a few years after not much happening, I then we've got other things coming through like Beovu, which kind of came and went. We've got Mvasi, which is a biosimilar, uh, Avastin. Then we've got Vabysmo. Then we've got Eylea HD. And now right at the end here, we've got our sort of dry AMD treatments sort of getting their approval as well. So it's kind of, you can see just even in the last sort of 4 years, we've had a real sort of influx of new medications to help our patients. And so why do we sort of innovate and sort of look to address these issues? Well, I think predominantly because a lot of these people are still quite active in the community and preserving, particularly people who are younger and middle aged, such as those with diabetes or with a family history of eye disease. It's really important to get onto those guys early to try and preserve as much vision as we can. And we can do things a lot of different ways. This is just a little summary about how we do things, whether we inject medications under the retina, whether we do implants such as your Ozurdex, whether we do ports, which are sort of a new thing which is coming out. We inject into the eye or the suprachoroidal space. There are a few different ways that we do it, but we usually do inject something into the eye so that we can really bypass a lot of the biomechanical barriers to treatment, infiltration into the eye and absorption into the eye. So we're sort of mechanically bypassing these things with an injection. And then, of course, we can also do that in our rooms and sort of watch this space, I guess, the role of optometrists and with these sort of intraocular procedures is sort of evolving in the near future as well. So just to be aware of sort of why we do these things and what the advantages are there. So some of the clinical trials I've been on, we've done the faricimab for wet AMD, DMO, for myopic CNV, and then we've got the high dose of aflibercept trials for vein occlusion, diabetes, and AMD. And then we look at sort of the dry AMD trials, which is sort of just coming out now. And I was fortunate to be a part of the Gale trial, which is run by Apellis. And so sort of looking to see how that helps our patients with dry AMD, because we know quite well over the last 2 decades that the wet AMD treatments are going okay. So why is it important? I think it's really important for all of us to be aware of dry AMD, because I remember from my early years uh, working in Adelaide, um, in OPSM, really dry AMD was really in the realm of the optometrist, and it has been for many, many decades. That's where the patients go. If they have a neovascular transformation, they go to the ophthalmologist, but really all the coordinated care and multidisciplinary care was really referrals to Vision Australia and psychosocial interventions were really predominantly run by optometrists rather than ophthalmologists. And that's still going to be true. Um, sort of moving forward indefinitely. We think that there's going to be about 1 in 7 patients over the age of 50 who have dry macular degeneration, and up to 100,000 people in Australia with geographic atrophy, sort of based off our population estimates. And so that's a lot of people who are getting serviced by the optometry community sort of on a daily basis. And we just need to sort of all be aware of who is going to be eligible for these treatments when they come out and what to tell them, and you know, is it something even to be recommended for people? So we think that the progression from intermediate to late macular degeneration is roughly a quarter of people over 5 years, and a lot of AMD is related to family history and genetic markers there. I think this is a really useful slide here, where when we talk about AMD, where we've got early, where you've got the small to medium sort of drusen. You've got intermediate, where there's some medium-sized drusen or large drusen, maybe some RPE changes. And then really late is dichotomous into whether or not it's a dry macula or whether it's a wet macula. So whether it's geographic atrophy or sort of macular neovascularization. And so, and obviously geographic atrophy is the one we'll be focusing on today, which is sort of characterized by the degeneration of the outer retinal structures of the RPE photoreceptors and choriocapillaris. And so well, I don't want to bore everyone to death with sort of pathophys, but essentially, when we come to talking about treatments, you'll see that this thing called the complement system is quite important for AMD. And when we look at, thousands of people with AMD, really, complement factor H, this gene, really seems to be quite commonly associated with dry macular degeneration. And what that basically does, when you have a genetic defect in that gene, is it gives the body, develops an inability to mediate the innate immune system of which the complement is a part of. And so you get overaction of C3b, which sort of damages the retinal tissues, and the photoreceptor RPE and choriocapillaris sort of complex. And that C3b is quite important when we talk about pegcetacoplan. How do we look at it? Well, really, I think we look at it clinically. We've got your sort of color fundus photography, slit lamp exam, and then we've got probably sort of newer technologies like fundus autofluorescence, which are increasingly utilized in sort of our wide field fundus imaging machines. And so really it's basically very similar to your fluorescein, where there's an excitation and emission wavelengths, which are separated by a filter to detect autofluorescence, which is basically looking at these retinoids, which accumulate in the retinal pigment epithelium. And so when you have black, as in this photo here, that means that the RPE is dead and no longer accumulating any of those pigments, so you lose your autofluorescence. And so this is just a nice comparison photo to show exactly what it looks like, the difference between a color fundus photo and the autofluorescence. And the autofluorescence makes your geographic atrophy much more easily identified. And when we're talking about the sort of features of GA, we all sort of know what it is. We've seen it every single day, but really you're looking at these sharply demarcated areas of RPE atrophy with increased visibility of the choroidal blood vessels, and that appears hypoautofluorescent due to loss of the RPE, which corresponds to those lesions. And now probably a little bit more exciting. I harp on about this sort of every time I talk, but this is really something of value to just be aware of. the nomenclature for how to describe the different parts of the OCT. I think it's extremely important. And one of the main reasons why I think it's important is even just something as simple as differentiating the difference between a pigment epithelial detachment, which can be observed, from subretinal fluid, which can't. And really, um, unless you sort of know that that's your RPE in a band here, and whether the sort of material is above or below it, that sort of changes the whole treatment paradigm. So I think this is just a slide worth looking at and just familiarizing yourself with the different layers of the retina, because I think now pretty much maybe I can't remember what proportion of optometry practices, maybe somebody will put it in the comments, but I think maybe 50%, 80%, something like that, of optometry practices have OCT now. And so this is the common sort of language. Are we getting any hits? Oh, perfect. Some questions. Good, good, good. Excellent. Loving it. Perfect. So this is OCT an OCT of geographic atrophy. And so the sort of three criteria there, which are important to be aware of, is the loss of retinal pigment epithelium and the photoreceptors. So you can see the ellipsoid zone continues to here and then abruptly stops. And then so you've lost the RPE and photoreceptors across the fovea. There's an absence of the external limiting membrane, so you can see that ends here. And there's an increase in choroidal hypertransmission. So that's basically where you see the increased signal characteristics underneath the area of geographic atrophy. So that is sort of, I guess, the technical OCT definition of GA. So loss of the photoreceptor and RPE, loss of the external limiting membrane, and an increase in choroidal hypertransmission. So those sort of three features. And when you start seeing these things come out, talking about geographic atrophy, you'll basically come across this term called C-RORA. There's I-RORA and C-RORA, and they talk about, and they're basically referring to the outer retinal atrophy. And the way I conceptualize it is sort of geographic atrophy is what you see in the color fundus photo, and C-RORA is what you see on the OCT. So just in case you're seeing that terminology around, that's all it's basically referring to as a cross-sectional description of the fundus color photograph that you're seeing sort of head on. There's sort of different ways we classify it. So there's C-RORA, which is complete RPE and outer retinal atrophy, or incomplete. And that's really just to do with the size. Well, part of it is to do with the size of the lesions. They're a strong risk factor for progression of the geographic atrophy, both independently. And so is this other term called nascent geographic atrophy, where you sort of get these small little areas of cell death, and they have an almost 80-fold rate of progression to geographic atrophy over 3 years. So these are high risk sort of features. So if you're seeing these little small patches of nascent geographic atrophy, even though, looking at this patient, you'd say they have intermediate GA because of their sort of large drusen, this is somebody who would need to really be under close surveillance to detect progression of their atrophy. These guys here, these little intraretinal hyperreflective foci, they're basically what you clinically see as RPE migration in the retina. So you've seen that every day. That's just what they look like on an OCT. They are an increased risk of progression as well. When you see calcified drusen or drusen that have different signal characteristics within them, they are also a risk factor for progression. So weird looking drusen, RPE migration, and these guys here, which are called reticular pseudodrusen. And once again, looking to the I guess right under the fovea, that little arrow, that's just pointing to a normal drusen, which is underneath the RPE. However, when you look in that sort of dotted box, you can see that these drusen are above the level of the RPE rather than underneath it. And these are called reticular pseudodrusen, and they are also a really strong predictor of progression to late AMD as well. So just being aware of those, when we're thinking about people with dry macular degeneration now, we're really sort of teasing out who are the people that we need to watch quite closely to see if they progress, and who are people that we can relax a little bit more about. And so if you don't have any of these features, you can breathe a sigh of relief. But when we start seeing these features, we probably do want to keep an eye on them quite closely. And so entering this new hope, and so we've got a few drugs on the way. So Cyfofra, I don't know if that's actually, I don't know whether the trade name or the generic name is actually easier to, or the chemical name is easier to pronounce. But basically Cyfofra is binds to that C3b. And as you remember from the CFH gene in the pathophys, that's kind of what gets upregulated. So it really kind of makes sense that this drug would work. And Izervay just treats one of the other complement factors, but mainly Cyfofra is the one that we're going to be starting to see more and more around town. And does it work? And yeah, we think so. So compared with sham, either monthly injections or 2 monthly injections seem to reduce the rate of geographic atrophy progression compared to sham. So we do know that that the injections do work at sort of preventing, at sort of reducing the progression of the geographic atrophy. So that's really exciting. But we do have a lot of unanswered questions, such as, does it add any quality of life benefit to the patient? Does it prevent neovascular transformation, or can they still get wet AMD as well? And if they do get wet AMD, which one do you treat? Um, I guess like all the drugs, they can cause inflammation in the eye. So, you know, some people in America treat the bad eye first and then treat the good eye just to make sure. And we really just need to make sure we're sensible about who's going to pay for this, because it is hideously expensive. So I guess looking at all of these things, um, I basically thought that people with early and intermittent AMD really need surveillance tailored to this sort of multimodal imaging and sort of history. But late AMD probably should be referred just so that we can determine if it is going to progress, because one of the main requirements for establishing treatment with these new drugs is that they do progress. And so we do need to see that progression towards the macula is documented before we progress. And so I think, it is difficult at the community interface with patients, and really struggling to make a recommendation about whether or not they would benefit from a fundus photograph or not. But certainly, I think if you're starting to see these multimodal imaging features, I think you could make quite a strong recommendation, because if we could even document from my photo at the time of referral to one of your historical photographs that there was a progression, that would just save the patient so much time, rather than having to keep them under extended periods of observation to show that their disease is worsening. So I do think if you're starting to see these things and you're wondering about, and you feel like recommending like an OCT or a photo, I think you'd be extremely justified to do so for these patients, just because we need to know that they're progressing before we can treat them. And so we're kind of sort of waiting at the moment. It's approved for use in Australia. It costs $3,500 an injection, which at every 2 months is quite pricey. So we will wait for that to get approved for PBS funding and be cheaper. But in the meantime, that's not really the only drug that we have. We are working on other ones that are oral tablets or subcutaneous injections under the skin, rather than just injecting into the eye. And so we're sort of keeping a close watch on that space as well. And so maybe we'll even see that patients move away from intravitreal injections for dry AMD in the future, but we'll wait and see how they go. This is another great case. So this is a middle-aged guy who had left eye pain and reduced vision. He had had a red eye for 3 months and a headache for 12 months. So whatever was going on had been going on for quite some time. And he had a pressure of 70, and they thought he had acute angle closure, so they uh, did a laser iridotomy and then sent him through for management of his acute angle closure to Sydney Eye Hospital, where I was working. His vision was significantly reduced, and his pressures were severely elevated. Eye was quiet, there was no inflammation, cornea was hazy, as you'd kind of expect. Um, and when we had a look into the posterior segment, of course, right eye is normal. There's a bit of a hazy view in the left eye. I don't think that's myelinated nerve fiber layer. I think that's just artifact over his disc, but it's a little bit hazy, a little bit of vitreous debris in the eye. And if you cast your eye down in the left eye, down into the infranasal retina down there, that's an area of interest for later. You can see this really unusual autofluorescence pattern here as well that didn't really fit with acute angle closure glaucoma. Macula was looking okay. Thankfully, his nerves weren't too cupped out despite the really high pressure and the prolonged history. And then when we had a look at that lesion in a bit more detail, um, and that's an OCT through it, it's actually an intraocular piece of metal. And so we really don't know how that got into his eye. And he's really not quite sure, but sort of strange things do happen. And I think it's just an interesting case, um, just to show that you know, sometimes if things don't really make sense, if you've done your PI and the pressure doesn't get better, sometimes you really do just have to keep searching for another cause. So it was quite an interesting case. And if you've got a cool $280,000, you can get OCT in your Optos. This is the one that they have at Sydney Eye Hospital, so we've got quite a nice one there. So we were able to OCT out in the peripheral retina, which was nice. How are you guys all going? You still with us? Still, we're on to the final section, the home straight. Keen for a little bit more? I Perfect. I'll try and keep this one a little bit interesting. So this is sort of what all of this other stuff is sort of building towards. Like, what does it sort of mean for your patients moving forward? And I think, really one of my earliest memories is sort of at the QUTI clinic, when I had a young guy with Stargardt's come in, and he'd been doing his research and reading about, transplants and stem cells and all of these things that could be done. And really, even back then, that would have been 20 years ago, we were sort of saying, look, you know, you know, we we're working on it. We're working on it. Something's coming eventually. But I guess it's kind of, it's a really quite a special time because we really are like that time is now. And so now is really when we are getting to treatments for these terrible, terrible blinding eye disorders. So, really before where people would, have retinitis pigmentosa, and we would start thinking about, when do we cancel a license and the peripheral fields and sort of avoiding phototoxicity and getting orientation and mobility training and all of those other things. And now we're sort of thinking, right, are you going to be eligible for some kind of treatment? So really that's sort of happening now, which is excellent. And I guess this point is that now that we do have all of these treatments, not just for dry AMD, but also these other non-AMD causes, we really sometimes need to think about what we're looking at and whether or not it actually is all secondary to macular degeneration. So when we know that basically if somebody had that patient with the Stargardt's, if we gave him the complement inhibitor, he wouldn't perform well, and we may be missing an underlying genetic disorder, and basically maybe also making it more difficult for him to get treatment. So when we look at things that cause macular atrophy and geographic atrophy at the macula, you've got AMD. So you've got your dry macular degeneration, so the drusen, vitelliform lesions, PEDs, all can progress your geographic atrophy. And then you've got your wet macular degeneration. So you've got your macular neovascularization, submacular hemorrhage, RPE rip. These are all going to atrophy your macula quite profoundly. But then how do you know it's AMD and not one of these other things? So things like chronic subretinal fluid from central serous, trauma, so like a resolved commotio, laser, laser burn. We've got lots of drugs out there like Plaquenil or pentosan polysulfate, or tamoxifen even people might be on. The high myopes, people with inflammatory eye disease, like resolved AMPI scars, or inherited retinal diseases. And it can get very difficult to sort of tease it out because they often look very, very similar. So how do we sort of work it out? And these are a few sort of illustrative cases. So this is case number one, and you can see these quite well circumscribed areas of atrophy and loss of the outer retinal layers of the RPE and the photoreceptors, loss of the external limiting membrane, hypertransmission defects. And this all sort of fits the criteria for what we were thinking would be super reasonable to call geographic atrophy. But there's some other little clues that it may not be for this patient. And he ended up having central areolar choroidal dystrophy from a PHPR2 mutation. And so sort of just difficult to sort of tease out, but not quite standard AMD. Once again, this one here, another, you know, patient who has sort of bilateral perimacular sort of loss of the RPE and photoreceptors. And this sort of pattern here is called a bullseye maculopathy type pattern because it forms a ring around the macula. And this is quite common. This is sort of ABCA4, which is Stargardt's disease. We've all got patients with Stargardt's. This is a patient here. This is an extremely common one, which I believe that almost every optometrist online tonight would be watching patients on an annual basis for this. This is patients with Plaquenil maculopathy. Once again, you know, the devil being in the detail of the history, finding out that they take these sort of medications as well. This is an absolutely outrageous case for a number of reasons, but once again, you can see all this, maybe not geographic atrophy, but you can see all this attenuation of the RPE and retina. This is once again, this is a bilateral bilateral presentation, but you can start to get the clue that that autofluorescence just doesn't look quite right for what we'd be expecting. And this is a mitochondrial disorder called MELAS, and mitochondrial encephalopathy, lactic acidosis, and stroke-like symptoms. And so, you know, once again, you know, just important to be aware that these sort of, if it's not consistent with your feeling of AMD, then you know, really, really a deeper dive is indicated. This one here, another iatrogenic cause. This is pentosan polysulfate, and patients take this really for interstitial cystitis, so for their bladders, and it causes this horrible sort of maculopathy, which doesn't reverse when you stop the drugs. So just once again, just to be aware, sort of on history. This one here, once again, geographic atrophy sort of appearance here, but this sort of a funny pattern to it. This is an older patient, and this is late onset retinal degeneration. But for all of these cases, you know, there are subtle clues here. Like this guy, when you dilate him up, these cases of late onset retinal degeneration have these really long, or tend to have these really long zonules. And so sometimes you've picked it up when you're looking at the anterior segment long before you even get to the back of the eye and have a look at the retina. And one of the other things I'd sort of bring your attention to, even for case one, you know, where are the drusen when you look at that OCT? In any of these cases, where are the drusen? And if you're not seeing all of those sort of signs line up, I'd suspect probably an alternative cause. And so things that I think would really support maybe this not being dry macular degeneration would be, you know, people with a strong family history that would really make me think, okay, is this something that's inheritable? Young age at onset, such as less than 50, I'm really strongly considering it. It's not a definitive rule, but, you know, if it's really symmetrical between the eyes, that's often not what we see with macular degeneration. When we've got the changes on OCT and autofluorescence that don't quite line up, and particularly, there's no drusen, there's no reticular pseudodrusen, there's no uh, RPE migration. There's none of those other features in either eye. We'd really have to sort of maybe put a shadow of doubt over the diagnosis of straightforward macular degeneration, and certainly in patients with syndromic features such as kidney disease or hearing loss or you know polydactyly or whatever else other feature the patient might have, then you'd really be strongly suspecting, is there an underlying diagnosis? And so how do we sort of manage these things? And that sort of upper diagram on the left just kind of shows a few of the genes that we have and that we see. And there's all these overlapping circles because often the genes do cause multiple sort of phenotypes. And so something that causes a rod cone dystrophy, such as RPE65, well, maybe RPE65 isn't a good example. What would be a good example? Like CRX can cause a rod cone dystrophy or a cone rod dystrophy, just depending on the patient. So, there's a sort of horribly complex overlap with all of these things, and we sort of send them away to the genetic counselors. We do all this fancy tests looking at the DNA, and sometimes we do mouth swabs just in case patients ever ask you. Sometimes it's a blood test, and sometimes it's a buccal swab. So not always often that invasive to perform. And then we really look at, and really from that we can tell if a genetic cause is of identifiable in about 2/3 of patients roughly. And so how do we diagnose it and manage it? It's really often not, um, it's really sort of often led by the ophthalmologist, but we sort of have to work very closely with many people, such as um, the optometrist, with the low vision services, with the social worker, with the occupational therapists, with the genetic counselors, and with the geneticists as well. And so this is a little flow diagram which just sort of shows that even if you're suspecting it's not macular degeneration and suspecting a genetic eye disease, it's sometimes actually not that straightforward to work that out either. And so we often work in large multidisciplinary teams to accomplish that. But then we can do, once we've figured that out, we can actually do some pretty remarkable things now. And so we've really got on the central column here is really all of the um, sort of agnostic treatments where we need the low vision and aids, we need orientation mobility training, nutritional interventions such as sort of avoiding vitamin E, high levels of vitamin E supplementation, psychosocial supports, financial support by way of sort of blind pension and NDIS. These are all really important things that apply to all of our patients. But then when we have a look at what we can actually do, we've got many, many things. And so we can do gene replacements, optogenetics, we can do retinal prosthesis and all sorts of things. And so some of the ones that we might have seen already, I'm not sure if you have heard of this drug called Luxturna for RPE65, rod cone dystrophy. We inject it under the retina, and that sort of overcomes the genetic abnormality so that the cells start functioning again and restore vision. But we also have that um, for other disorders such as RPGR. I was very fortunate to be able to do intravitreal injections for autosomal dominant optic atrophy. So we inject this genetic material just into as a like you would inject your Lucentis. So that was minimally invasive for some of our patients. You can do stem cell therapy, medical treatment. One of the ones I would point out to you that you're going to see a lot of, especially coming from my patients, is something called N-acetylcysteine, which has been around for 1 million years, in terms of treating paracetamol overdose and renal toxicity from drug overdose or contrast. But we do find that it scavenges free radicals and sort of is a really nice agnostic therapy for our patients to sort of preserve their vision. And then we've got the retinal um, prosthetics. That's just come out in the latest edition of Clinical and Experimental Ophthalmology. So it's highly topical at the moment. And then we've got gene editing systems which we can use. And through my role at the SaveSight Institute in Sydney, we do have lots of clinical trials up and running, such as Abacus 2. And this is for our patients with very low vision with retinitis pigmentosa. We do an intravitreal injection, and it induces a photoswitch molecule in the retinal ganglion cells, so that the retinal ganglion cells do the phototransduction, or well, I guess a crude phototransduction to produce vision rather than the photoreceptors, which have all atrophied. So that has been performing very well. We've got the Nacuity, which is N-acetylcysteine. We've got the OPA1, which is the injections that are the antisense oligonucleotide injections for autosomal dominant optic atrophy. And then we've got Luxturna, which we treat some of our patients with. And I think we've had 2 patients from Queensland already be treated with Luxturna down in Sydney already, which is great. So this is just a final sort of case to sort of finish things off. So this is a low myope with a bit of visual reduction in both eyes, healthy anterior segments, and you can see bilateral foveal atrophy there. And when we do the autofluorescence, you can see that it's quite striking atrophy of the macula. But I guess noting that it does have this hyper-autofluorescent ring, which we really wouldn't be expecting to see this in dry macular degeneration. So, but once again, looking at the OCTs, there is macular atrophy on both sides, but there doesn't appear to be any drusen or any other stigmata of dry AMD to support that diagnosis. And so this patient had a CRX gene diagnosis, which is, I won't bore you to death, but it's a pretty cool gene. And it's basically one of the early embryonic genes when your retina is developing, which sort of helps the different photoreceptors differentiate between rods, short wavelength and medium wavelength cones. There's sort of this genetic interplay that causes the cells to differentiate, and it's responsible for that. And the other thing that it does is it binds up, it promotes IRBP. So if you remember your phototransduction cascade, you've got intraretinal binding protein, and that takes the sort of all-trans retinal from the photoreceptor, all-trans retinal to the RPE, and then cycles the 11-cis retinal back into the photoreceptor to sort of recycle those visual pigments. And so without IRBP, there's sort of this macular atrophy which kind of develops. But I guess, cool story. What does that really sort of have to do with anything? Well, I just thought it was really quite interesting to sort of show exactly how far we can go with our new technologies. And so even though this is a rare sort of mutation that we wouldn't have come across, when we have a look at our CRX patients, we differentiated the study investigators differentiated some stem cells from the patient, and then terminally differentiated them into retinal organoids, so it forms a crude retinal structure. And basically what you can see here is on the top diagram, looking at the controls here. Can you see my mouse sort of circling there on that? Yeah, perfect. Yep. So you can see this sort of the rhodopsin photopigment staining in red there in the normal eye, but in the CRX eye, you can see that there's no rhodopsin. And then after it's been treated with CRX from an adenoviral injection or transfection, you can see that it's producing rhodopsin again. And similarly with the long and medium wavelength photoreceptors, you can see that they are starting to grow back following sort of treatments. And similarly, sort of in the bottom diagrams, you can also see that in the untreated patient in the middle sort of row, really not much is happening with any of the pigments or the opsins at all. But as soon as we transfect it with the appropriate gene, we can see that there is um, a a recovery of the photopigments and regeneration of the photoreceptors. And this response was present out until 300 days in the retinal organoid. And so this is the kind of technology and studies that are being done to uh, basically be translated into human clinical research. And so I guess when we're finding all of these patients and we try and see them either in, Michael Hogden's clinic at the PA or my clinic at the Royal or at the Children's Hospital, what we're trying to do is identify not just the patients with dry AMD that we can treat with our injections, but also try and find the ones that don't have AMD, so that we can actually try and get them enrolled for treatment when it becomes available, and all of that stuff is just on the horizon. So it's pretty exciting, and we'll soon be able to, provide a little bit of hope for our patients, I think. So in summary today, I think in the past, there's no shortcuts. History and examination are key, and we've all got a really strong idea of when we're going to refer those patients with the red flags, and certainly, sort of those features of the unwell patient, pregnant patient, immunosuppressed patient, only eye. Really we need to think critically about those people. The present, really, we're absolutely living in a golden era of treatments already. As you could see, we've got so many more now than we had before. We sort of know the role now of the complement system and why Cyfrophora should work for our patients. And now I hope, despite my nattering on for hours about it, I hope we've got a good appreciation of how those sort of fundus cameras, the autofluorescence and the OCT that you'll be doing every day can sort of help you make these diagnoses for these patients and counsel them appropriately, and certainly, feel confident in risk stratifying your macular degeneration patients, or knowing when they're not when you don't suspect that they have macular degeneration. And in the future, I think we really just need to find these people who have these genetic eye diseases, molecularly clarify them with DNA analysis, and then start offering them treatment. And I think, if anyone's sort of an older member of the audience, you may remember vividly, like telling people for years, oh, they're working on it, something's coming, but really it's here now. And so, it's a really exciting time. So it's a pleasure to have been able to present to you today. 1 hour, 2 minutes, 17 seconds. So I've run over a little bit, many apologies. But hopefully there was something sort of useful there, a bit of something for everybody, to sort of just see exactly sort of what we can do, and how we can work together to make things better for our patients. Thanks so much for listening, guys. Were there any questions, Beck? Belinda?
There's
Oh, okay, far away. Thanks, Jen.
Oh, just wondering how often we should be reviewing or watching PEDs.
Yeah, great question. Great question. So let's go back to a PED. Too many slides. Okay, so I think a PED in and of itself, so these ones here are what we would call drusenoid pigment epithelial detachments, right? They've got that sort of homogeneous material that lives in them, and when you see them clinically, they're drusen. And in and of themselves, they're not too high certainly early drusen are not, those drusenoid PEDs are not really at high risk of doing anything. And so they could really be watched on an annual basis. For our intermediate AMDs, I think every 12 months still is reasonable to keep a watch, but with a small caveat that if you were noticing some of the other features like the RPE migration, reticular pseudodrusen, sort of weird sort of drusen associated with the pigment epithelial detachments, I would really, in the first instance, have a low threshold, maybe to just see them again in 4 months and then extend their interval out once we've documented that they're not progressing or worsening or becoming associated with subretinal fluid or some other change. But, you know, if the patient was sort of symptomatic with metamorphopsia or had become acutely aware of a change in their vision, then low threshold to keep them under closer surveillance.
So you would give them an Amsler grid, much like any other AMD patient.
I think that's reasonable. We don't really have any way of treating them until they do have a neovascular transformation, or you do get the vision, the macular threatening GA. So really up until that point, all we can really do is try and enlist the help of the patient as well with an Amsler grid to help us monitor sort of MacuVision AREDS2 formulation, supplementation, quit smoking, make good choices. I think that's all, that's really all you can do. What's your sort of practice pattern, Joanna?
I refer it to a really smart person like yourself.
Yeah, I mean, it's not unreasonable. If there's no subretinal fluid, we'd probably just keep it under watch as well. And so I think, you know, if it's really low risk, you know, we just see it every year. But if you know, there's features indicating sort of something that could be a risk of progression to late AMD, you know, initially, just like how you might watch a nevus that you weren't aware of before, or a patient hadn't noted before, and you weren't really sure if it was new or old, and you might just keep a closer watch on it initially before extending out your reviews.
Okay, great.
Thank you so much.
Any other questions from the audience? Jay's just asked me if you have a preference for an AREDS2 supplementation or vitamin.
Yes, I do. Like just full disclosure, I have no financial interests or any sort of disclosures to sort of enlist, but I've always liked those MDIs or whatever, just because I think they do work out to be cheaper for the patients in the long run, but it does mean they have to order them online, which I think a lot of elderly people can't do. But I think that's the best value for money. What do you guys think?
I think sometimes, yeah, due to availability to the patient, I might,
Yeah.
and you know, the internet is a bit of a scary place for them.
Yeah,
I'd
true. Yeah.
rather them have some kind of AREDS2 than none at all.
Yeah, definitely. Definitely. Like a Blackmores or something like that. Or what are the other ones around? There's a few. Mm,
Yeah, that's right.
perfect. Perfect. Thank you so much.
Oh, we've got another question. Does
Ooh.
electrodiagnostic testing play much of a role with diagnosing genetic conditions?
Yeah. Perfect question. Yes, it does. It very much does. And so um, part of the big reason, there's a few good reasons. One, it's because even with all the best genetic testing that we have, we can only really find a cause in 60 to 70% of our patients. So there's a large proportion of people that we think have a genetic eye disease, but we don't have the technology yet to diagnose it. And so it's really quite helpful to confirm exactly what type of disease they have, even if you can't find a specific genotype. The other reason as well that it's helpful is for eligibility to enroll in the clinical trials. And so really, to prove that they have enough visual function that could be resuscitated to be eligible for treatment, they need to have electrodiagnostics to do that. So there are a few good reasons to do it, to monitor the rate of progression. We can sort of coarsely prognosticate how many years of useful vision somebody might have left as well when we do it. So there's lots of good reasons to do electrics. Great question. Do we have some like CPD-ish multi-choice questions for people so that they can
Question
get
one,
on with
which of the
their
following
dinners
best
and
describes the mechanism of action of, oh dear, pegcetacoplan in the treatment of AMD?
which was that one? What was that? Sorry, Joe?
Which of the following best describes the mechanism of action of C4 in the treatment of AMD, dry AMD?
Yeah, perfect. Are we just sort of like putting it open to the group, just putting it in the chat? Perfect. And they've all got the questions?
Yes.
Oh, sweet. Cool. I didn't even know. Yeah. Great. We're getting there. Perfect. How good. So did everybody, I can't see the answers from here, but presumably something to do with C3b complement. Perfect. I think that sounds about right. I'll go over this way. All right, perfect. Any questions about that? I think that's right. Yeah. Complement C3. Perfect. Yeah, cool. All right.
Which OCT feature is not associated with accelerated progression to geographic atrophy?
Perfect. Ooh. Yep. Perfect. Good. How do we go with question number 2? What are we thinking, guys? And so this is a bit of a different one. I think it's B is the answer, shallow irregular RPE elevation, which is another sign you'll see coming around, and that doesn't cause geographic atrophy on the OCT. Question number 3. Are we cool for question number 3, Joanna?
Yeah. What is one key consideration of current treatments of dry AMD, such as C4? I'm not sure if I'm saying that right.
It's literally the worst. Out of all the names you could choose, that's just like defies logic. Let's invest $1 billion in a drug that no one can pronounce. It's the dumbest thing ever. Anyway. Perfect. And do they pop the answers in anywhere or?
Oh no, we're waiting for you to tell us the answer.
Oh, right. Oh, cool. I'm waiting for you. Oh, this is hilarious. No. Oh, cool. No worries. Yeah, great. So, essentially, yeah, they're gonna write. Look at this. Look at the comments, man. What are we talking about? I don't need to say anything. Yeah, C, right? Like, these drugs slow the progression. They don't reverse the atrophy. So, it can be a tough discussion to have with people that we inject you every 2 months forever and you will never improve your vision. It's a tough sell. So that's why we're very selective about which patients may benefit. Okay. Question number 4.
Which diagnostic imaging modality is the most useful for monitoring GA in dry AMD?
Oh yeah, great. Excellent. Yeah. So what do you guys reckon? B, perfect, awesome. And I hope that came up in the images, like just how just superbly you can see it on autofluorescence. It really is quite easy to see, which is great. We took out OCT from there because I didn't want to have autofluorescence and OCT. I thought that would be mean to try and choose. All right, question number 5.
Why is early detection of GA important in the context of new treatments?
Oh yeah, cool, great. Yeah, a collaborative question with a collaborative answer. I like it. Yeah, perfect, smashing it. Who got there first? Selwyn, you gun.
And Beck's in there.
Beck's in there. We'll have to have a tiebreaker, question 6. Yeah. So basically, we really have to detect progression. And so yes, even the vision loss is irreversible, sorry, even when it's just detected initially. But because we have to prove that it's progressing to know that treatment will slow it down, that's why it's sort of really quite critical to sort of photo document these things from time to time, which is good. Oh, how great. That's so good. I'm so happy, guys. Oh, there was another question here. For patients who have GA in one eye, is there any data to indicate the likelihood of progression to late AMD in the other eye? Yeah, there absolutely is. And so a lot of that information about progression from dry AMD or the other eye risk comes basically from from our longitudinal studies, population-based studies that we've done. And it's not an insignificant risk. I think it's like 1 in 4, 1 in 5 people do progress to developing more severe AMD in their fellow eye. And I think that was the whole purpose of the AREDS 2 clinical trial, was to show that really they only found that the oral supplementation worked in patients with grade 3 or grade 4 disease. And what that basically meant was that somebody had to have, one of those groups was ones that had to have bad vision in the other eye. And then it was like basically a 25% risk reduction. So basically the risk of transformation in the good eye went down from about 15% down to about 12% with sort of AREDS 2 supplementation. So there's like a 25% risk reduction with supplementation, but the absolute risk reduction with taking is about 3%, and that takes it down from about 15 down to about 12, I think. Yeah. Yeah, it's about 15%. Cool. Anything else? No? All good?
Well, thank you to everyone for joining our very first inaugural webinar series. We'll be doing them every 4 weeks on the 3rd Wednesday of every month. So in 4 weeks' time, we will hear from Dr. Ryan Nugent. If you want to tune in with your glass of wine in hand and ready for some keen CPD education. And thank you again to Dr. Newman for such a fantastic presentation. We certainly does shed light on the future of AMD.
Oh, thank you to both you and Belinda as well, Joe. But honestly, thanks everybody for coming out. I mean, it's fantastic, huge turnout, and absolutely loved it. Thank you so much for coming, guys. I really appreciate it, and hopefully you can get back to your Wednesday nights and enjoy what's left of it. Thanks so much.